I'm Sheenagh Orchard. I'm a nurse by background and have been a ward manager, a senior nurse tutor, moving and handling specialist, risk assessor of complex cases. So I've got a finger in a lot of pies, and that's helped me very much to look at the aspect of safe patient handling from a lot of different angles. And I think you'll see that although this is called evidence base for complex assessment, what I'm trying to do is to pull the information you've had on the first two sessions into a practice base. Because at the end of the day, all of this, the training, the management systems, your ergonomics, the whole of it is focused on ultimately delivering good outcomes for our patients. And I'm going to look at it from the situation of various aspects of care and link that back to how you apply the ergonomics that was looked at from your first speaker, and also how you link the training to get this effective outcome. And you'll see that it links very well with all the things that have been said previously. One person asked a question of how do you change attitudes? How do you actually get this to work? How do you get managers to look at this differently? And having been a trainer, going in as an external trainer myself, and considering how we need to influence change, one of the things that's helped me enormously over the years is, although we come from a health and safety angle, it's a poor effector of change to go in and tell people your health and safety improve, your back care will improve, to carers that your injuries will reduce. Although it's valid and it's true, it doesn't affect change very well in care sector, in my experience. What does work very well is to question the standard of care being received and delivered. And if you look at the interaction between quality of work, where you've got good management systems, good ergonomics, good training, if all of that is working well, it will reflect in high quality of care, in good care standards. And so if you effect change from the care side and influence people from the care side, automatically your work systems will improve anyway. If I give you an illustration of that, if I go into a care home, a ward department, where people are reluctant to use sliding systems, now, I know that it will benefit them from an organisation point of view and from a work systems point of view and from a personal level for carers to improve their back health. I won't go in with that sort of debate. What I do is go in and say, what is the impact on your standard of care of not using sliding systems? And so the whole emphasis is, if you use this for patient A, we will improve the tissue viability. We will reduce the hands-on body contact needed, which is painful for them. Every time you lay hands on their arms and legs to hoik them up the bed, that's painful for them. It's emotionally undignified. And the practitioner is more likely to think, a slide sheet might improve things for my patient. Because that's why we've all gone to work. We've gone to work to deliver high standards for our patient. And so if I can identify for them the improvement in patient outcome from a management, I find people are much more willing to listen to the change, and I'm more likely to affect the change. And care is good business. If I go to a manager and say, you're not delivering the standard of care that's required here, if I go to a nursing home manager and say, your standards are not meeting the current best practice, and your care delivery is not meeting current best standards, they're much more likely to pay attention to that and improve than if I go in and say, your care staff are hurting their backs. Although both cases are valid, if you go in with a health and safety perspective, people are quite resistant to listening to you. If you go in with a care aspect of why you want to implement change, people will listen less reluctantly. And so if we look at safe patient handling, always there is an impact on the patient, on tissue viability, on pain, discomfort, musculoskeletal injury to the patient, and the emotional comfort and dignity of their management. So in answer to that question, I would say look at the care angle that you're hoping to improve with your training, your equipment provision, etc. Move past that. Now, when we come to look at care nowadays, we are meeting more and more complex cases. Patients and clients are presenting with increasing need for complex case management. We've only got to look at the bariatric sector of our caseload and looking at the complexities and how people don't fit into the nice, neat pigeonholes of basic training and basic equipment. Therapists and assessors are constantly being challenged on particularly the cost of the complex case management, and so they've come up with good processes, good managements, and that's been questioned very often because of cost. It is imperative that we meet our individuals' needs, that their outcomes, both from a medical and a welfare point of view, that we meet those to the right standard. And how do we ensure that the individual's need is kept central to the decision and demonstrate to clinicians and budget holders that our assessment is valid? And if we look at assessment underpins everything. We've heard a lot about ergonomics. We've heard a lot about training being part of ergonomics. Risk assessment is part of the ergonomic process. Training is only one element, and we've got lots of research and studies that shows training on its own is not effective. You have to take this holistic approach to your management. And trainers need not only to be very focused on the programs, the content, but they must understand the implications of their training and its relationship to the risk assessment of the individuals that those carers who are trained are going back to support. And if trainers don't have sufficient understanding of the cases that their learners are going back to support, they will give inadequate information to those individuals. Again, if I give you an illustration, I work in a very high-risk small home with people with very complex physical and behavioural issues. They employed an external trainer who came from a very much less demanding care sector. The trainer went in and quite perfectly valid said, people are on the floor, we need to hoist them to get up from the floor. And immediately there was an antagonism from the group because they know that their client group, if you bring in a hoist, they've brought in a weapon. And so hoisting for those individuals was not an appropriate way to help them up from the floor. And that lack of understanding of the trainer of that particular workplace setting and the needs of that workplace setting meant that the training really didn't reflect the practice because they didn't understand the assessments of the individuals who were in that place of work. They were training with a very different assessment base than the care setting. And of course, if you've got that very disparate view, then immediately the delegates are not going to listen to anything you say as a trainer because you've said one thing that is completely out of sync with what they know is their working practice. So they'll disregard everything you say, not just the elements that aren't helpful. So although I'm talking about risk assessment, it's very important that trainers understand the assessment of the area you have gone into training. If we look at competency, and if you look at, again, there was a question raised about passing or failing in standards in manual handling. And we don't have a pass-fail in most settings, but we should have competencies that have to be met before people are allowed on to the next stage, which is in effect a type of pass or fail. But some people will never reach certain levels of competency, and their work should be designed around the competency they have. And some of these things that I'm going to say about the competent assessor are equally true about a competent trainer. If you're going to have a competent assessor, well, firstly, in UK, that is required by law under the management regs that every employer shall appoint one or more competent persons. I think it would be helpful if within law we had some equally strong statements about competent trainers. But we've never really had a national standard about what is a competent trainer. We are getting there. We've got guidance documents, but we've got nothing in law that actually defines a competent trainer, and that causes a problem for us in the UK. We've got very, very varying standards. Who is regarded as competent? Well, it doesn't matter whether you're an assessor or a trainer or a manager. Competency is about having sufficient training, experience or knowledge and other qualities to enable you to properly undertake those measures that you are involved with. And part of that is about your own accountability of your competency, and part of it is about an employer knowing what competency they're looking for when they are employing someone for a role. When it comes to complex case assessment, then obviously the competency broadens. You need someone with a wider knowledge and understanding and how to apply that knowledge effectively. And that's equally true for training. If you are training in very standard, basic settings where core practice works fine, if you're going to deliver training in a complex setting, then as a trainer you need to have advanced your skills and knowledge and experience to match the complexity of the cases your students are going back to. Really important that both trainers and assessors understand the law, and that's very different than knowing the law. It's that understanding of law and its interpretation that is critical. You need to know it sufficiently well that you're not swayed by myth or opinion. Now, I don't know what myths fly around over here in Ireland, but we've got quite a few over in the UK. That did you know that you're not allowed to lift legs into bed anymore as a practitioner? You cannot use a hoist except with 2 carers. It's illegal. So we do get a lot of these myths and opinions, and they develop from a seed of sense, but by the time they've grown, they've become these ridiculous statements. And so when I go in and look at single carer hoisting, albeit with overhead tracking, not a mobile hoist, then the group will look at me and say, well, this is illegal, Sheenagh. We have to have, the law says we've got to have 2 people. And I'll say, where? You've got to know the law sufficiently well and understand what it means. So, like you, we have got in the manual handling legislation to avoid hazardous handling where it is reasonably practicable. And where it isn't reasonably practicable to avoid the hazardous handling, you must assess it and reduce the risks down to a reasonable level. And if we look at hoisting as a case, it is quite obviously often unreasonable in some settings where you've got poor flooring, heavy clients, complex transfers, to expect one carer to hoist on their own, apply a sling and move a mobile hoist from A to B. But it isn't the law that says you can't do it, it's the law's requirement to do a risk assessment, and that assessment to identify the risks and reduce the risks that tells you it's unreasonable. So it's all founded on the assessment. So I can say, as long as my assessment has looked at all the aspects of that hoisting situation, if my evidence leads me to say this is perfectly acceptable to be done by a single carer, and it will only be acceptable if the ergonomics have been really looked at, the patient themselves has been really considered, and the whole effort of the job has been considered. But we have many cases where we hoist with a single carer. And I can do that because the law only tells me to avoid where reasonable, assess what can't be avoided, and reduce the risks to a reasonable level for that situation. But it's case specific. And so it's that depth of knowledge of the law that helps you support your decisions. It helps you as a trainer to go into a nursing care setting and saying, it's not me who says you need to do this. The law requires both of us to do our bit to achieve this. And therefore it gets less personal. It's much more objective instead of subjective. If you're going to be competent, you obviously don't only need to know about the law and its essence. You need to make sure that everything you say and do as an assessor or a trainer is evidence-based. It can't be based on your personal opinion or whim. Your opinion must have been identified from an evidence source. And so you need to demonstrate sound knowledge both of current best practice and knowing what standard people expect of you today, not what you did 5 years ago, 10 years ago, or if you look back, I've been nursing 40 years, and if I went and did now what I did then, I would be hopefully struck off really, but I wasn't wrong at the time. Okay, it's about current best practice. And if you look at best practice guidance from the Nursing and Midwifery Council in UK, one of the elements that constitutes physical abuse is inappropriate manual handling. And that is actually written down in our codes of conduct. Not poor manual handling, unsafe manual handling, inappropriate manual handling. And that leads us to say it might even be a known safe technique, but if it was wrong for that patient and it's inappropriate, that still constitutes physical abuse. So it's not even just the controversial techniques that we're questioning here, or negligent manual handling. It is, are you delivering manual handling that is appropriate for that individual? And if not, it could be constituted as physical abuse. And raising that to some managers and saying, I can identify several of your patients who they may be managed with safe techniques, but they're wrong for those individuals. And actually I am questioning whether there is some physical abuse going on here with your patient group. That scares the hell out of them. Because actually what you don't want is any question marks of you abusing in your care setting. If we look at what other things we need to be really confident in our knowledge on. And if I go back to best practice, you need to be looking at what current documented guidance there is on best practice. And in the UK, we've got, as the previous speaker identified, we've got the Guides to the Handling of People. We're now up to the 6th edition, and that is used a great deal as our documented evidence of what practice is seen as current and is seen as acceptable by our peer group. They're not the only guides out there. There's plenty of other good documented guidance. We also need to have a sufficient depth of knowledge of biomechanics and normal movement. And if we don't, in our training and our assessment, take account of normal movement, we make the movement much harder for the person we're moving, harder for them to do it for themselves. And of course, if they're finding it harder to move themselves, who's going to pick up the extra work? The person assisting them. So everything has a knock-on effect. If you don't look at good biomechanics, if you don't look at normal movement, if you don't marry up your techniques and your prescribed managements for patients around those principles, you make life harder for everybody. It'll get done because carers will get it done, but it will be much harder and much less pleasant for everybody involved. We've heard a lot about having a good, sound knowledge of ergonomics, and I'm not going to expand on that. You've had some very, very good direction in relation to ergonomics, but it's fundamental. I can train people how to do a bad job better, but it's much safer to build out the human element and give them a job that just is sound. It's not a handling illustration, but it's an illustration of how if you use ergonomics well, you prevent people getting it wrong. One of the terrible train crashes we had over in the UK was when a train driver couldn't see the red stoplight as he was driving because trees had grown over the light. And so he missed the stop sign and so didn't stop the train. And hence there was a train accident. An ergonomic intervention would have been that whenever a red light comes on a track, there is an automatic stop in the rails, so the train is stopped every time there is a stop. And the driver has to override that if he assesses that it's okay, or he rings in and says, "Can I override it?" or he stops. Now that means that you eliminate human error to a degree. And that's always the basis of good ergonomics, is not how easy is it to get it right, but how difficult is it to get it wrong. You want to make it really hard for people to get it wrong. And you do that not by training so much as giving them systems of work that just flow successfully and well, that they don't have to think too hard about. So ergonomics is vital if you're going to get safe practice. Knowledge of equipment is equally vital, and you need a depth and breadth of knowledge of what's out there, keeping abreast of the changes in equipment. And we'll look at some bits of equipment as I progress to give you an illustration of that. Obviously, you must be confident in your own level of competency. You are accountable. We must know where to source and use evidence that we source to support our decisions. And at times we must be able to produce our own evidence to support our decision, and we use ergonomic tools. And I've used the Finish tool for many years. There are many, many tools out there. I look at a few that we use a lot within patient handling, and certainly were the tools we used for the Guide to the Handling of People to make decisions about techniques. But there are things like REBA, Rapid Entire Body Assessment, BORG, which looks at perceived exertion of the person doing the job, FIM, Functional Independence Measure, for looking at the ability of the person who's being moved. Just out of interest, how many of you have heard of REBA, BORG, FIM, tools like this? Brilliant. About 5 years ago, if I'd asked that question, there would have been very many fewer hands, so it is getting, the information is getting out there. And we do need to use those at times to create our own evidence. And we must be able to undertake analysis of equipment so that, reps will always tell you they've got the best bit of kit, and so will the next rep. And so you've got to be able to say, what is it that makes this good? When would it be most valid? And do the pluses and minuses of that equipment suit my situation? And making sure that you realise that every piece of equipment will be brilliant in the right setting, but every piece of equipment has negatives, and you need to be aware of those so that you're not marrying them up with the wrong situation. The other thing that is coming forward a great deal, in the early days when the EU regulations first came out, 93, and the directives were coming out, there was a bit of a knee-jerk reaction on manual handling, where if someone couldn't move independently, they were hoisted. There was no middle road. You were either an independent mover or you were treated as completely dependent and hoisted. And of course, that's very bad for lots of reasons. It immobilises people, stops using function, and hoisting has got its own very significant risks attached to it. And we need to be sure that we are not too risk averse in healthcare managements. Health and safety is important, but it mustn't take precedence. It must be looked at. We talk about balanced decision making a lot, about balancing the health and safety against meeting the outcomes and needs of an individual. And positive risk-taking is nothing new. It's been discussed in healthcare, a study on healthcare in later life in 96. So, it is not new, positive risk-taking, but we need to empower staff to think that way. Hayes in 92 even suggested that the notion of risk as a wager, if you like, assessing the losses and gains, and if we put that in modern terminology, that is your balanced decision making. He said, or I can't remember if it was a he or she actually, it's a Francis with an E, that would seem to be a more appropriate conception of risk, rather than this very risk-averse, we can eliminate it, we can get rid of it, because you can't, because every risk that you put right will have brought with it a new risk, which you have to be aware of. And at the end of the day, risk-taking is a normal part of daily living. We're all at risk all the time. Do we worry about that? No, what we do is balance up the benefits of what we're doing with the negatives of what we're about to do, and if the benefits outweigh the negatives, we'll do it. Along with that, of course, comes people's different levels of perception of risk. I, for example, find it hard to get on an aeroplane. I did to come over yesterday, and I got here safely, hopefully get back the same way. Other people go up in aeroplanes and jump out of them. So we do have different levels of risk-taking, and of course we will bring that both to our training and also to our risk assessment. But we do need risk to enable people to lead a fulfilled life and for people to meet their potential. And what we don't want for our patients is for them not to reach their full potential. And therefore the things we train our staff should be about facilitating an individual to meet their mobility needs, not we do it for them. The benefits for an individual of positive risk-taking, I think they're fairly obvious. They increase emotional, physical independence, gives people a greater ability to make choice, increases confidence, they regain control over their lives. But also, from a social care point of view, the benefit is in cost, because if people are more independent, they need less supported care. And there is a cost implication there. There obviously are negative outcomes of risk-taking, and that is possible injury, which we mustn't ignore. And each case must be considered individually. And you have to come to an agreement with all parties as to what level of risk you're prepared to allow. So if we look at best practice, there is guidance, but you also need to be able to know how to develop your own best practice. And one of the dilemmas in training is that however long you give people to train, and the recommendation in the UK from the Health and Safety Executive is that people who are new to care should get 5 days of training. There's no way we meet that in most care settings. It's not saying that all that training should be in a training room, because most of the valid extension of training takes place in the workplace, but you need, as a previous speaker said, you need that support in the workplace. You need key workers, you need mentors, you need support and supervision in the workplace. When we train, we can only deliver so much. If I could take a whole day, probably more actually, showing you all the things you could do with a slide sheet, the different ways of putting it in. I can think instantly of 6 different ways of putting a slide sheet under a person and bed. Now, you can't possibly train people in one go for that level of knowledge. They'd forget everything. You know, they get so swamped, they just wouldn't have a clue. They'd go away and think, oh, I don't remember anything. So what we do as trainers is we tend to deliver core skills training, the essence of what they need to know, the basic skill. The extension to that should happen within the workplace or on updates, bringing people back, so they're continuously learning and expanding on their knowledge. You need to recognise that every practitioner has different ways of approaching things. And so I've said I can think of 6 ways of getting a slide sheet in. I could have 6 trainers who all pick on one of those as their preferred method. And if a practitioner goes to each of those trainers, they'll be shown a different method each time. Now, whilst it would be helpful if they looked at that as, oh, I'm building on my knowledge, I've learnt another way and another way and another way, what happens is they go and say, I've been shown differently. Either my last trainer was wrong, or you were wrong. And the reality is, neither were wrong. They're both right, they're just different. But practitioners find it, they want to be told, this is what you do, this is how you do it, and it's the only way to do it, and if you follow that, you'll be fine. And of course, it's not like that. And as trainers, you've got to be a little bit open-minded. You will have your own preferred method, you'll have your own preferred holds, the way you like to put a slide sheet in. I like to put concertina and I put it in the middle. I like to fold it up and put it from the top. I like to turn someone on their side. But they're all just likes, actually, of 3 methods that are all perfectly acceptable. What's important in best practice is knowing what's different and acceptable and what's different and wrong. And if you look at core skills practice, that will be giving you the essence of the move. the principles that must be applied if X is going to occur. And so when I'm working with nurses, OTs, physios, and they're all sitting there thinking, well, I was taught this way and Sheenagh's wrong. I'll say, look at what I'm doing, look at what you want to do, and do both methods apply the principles? If they both apply the principles and they get the achieved outcome, they're both correct. They're just different. A lot of people seem to have difficulty getting their heads around that, so I tend to bring it down to everyday life. When you make a cake, there are certain ingredients that must be present to get a cake, not a souffle or a biscuit. It's a fact of life. Everything has its set of ingredients. So let's say a cake takes flour, raising agent, eggs, fat, a tin and a heat source. I can say that if I use those ingredients, I will get a cake. Someone usually chirps up and says, what about sugar? And I'll say, hang on to sugar for a minute, because it's a bit of an oddity. I can make a perfectly good cake without sugar. I cannot make a good cake without a raising agent. And that's the difference between a principle is a must. So in patient handling, a must is, I must achieve the outcome I've set to do. I must have looked after the musculoskeletal health of the person doing the job. I must use spine in line, flexion, transfer of body weight. Those are musts. If I'm looking at sit to stand, a must for the patient is they must have their feet on the floor. Would you all agree? Is it a must? Yeah. You're not going to stand up if you haven't got your feet on the floor, so it is a principle, it is a must. Where you put your feet can be variable. So some people stand with their feet, both feet underneath them. Some people have both feet under their knees. Some people have 1 foot forward, 1 foot back. Those are sugars. They're almost a principle. They're bonded to a principle, but they can be variable. You've got to have your feet on the floor, but actually you can have them apart, you can have them together. You all will all stand up with your feet in very different places and you don't fall over. Now that gives me my core skill, but it would be very boring life if you only learnt how to make a Victoria sponge. Some people like fruit cake, some people like lemon drizzle cake, some people like, I don't know, chocolate cake. Yes, I always miss out chocolate, it's not my favourite. Those are your differences in practice. They're all cakes, but they have got what I call variances to them to give you the different flavours, extras. And it's that variance in practice that you see when trainers say, this is the way I put the slide sheet in. Oh, well, I do it this way. Who's right? Both of you are. One of you's chocolate cake, one of you's fruit cake. But you're both cakes. Am I making sense to people? Because we tend to get very precious about our training and what we teach people. And you feel a bit challenged if someone says something differently. Keep your mind open and say, it's just because I like chocolate cake, you like fruit cake. I'm not going to change, but I'm happy for you to deliver your cake your way. However, both of you must be using the principles. If a principle is not being applied, then actually you haven't got a core skill. You have got incorrect practice. And that's the essence, if you like, of looking at controversial techniques. They are getting a bit far away to be underpinned by really sound principles. And of course, principles change as we get more knowledge and understanding and research about practice. These are the tools that you might use if you're trying to evidence your variance in practice. So if we look at a core technique of sit to stand, as described in nearly all the handling books I've looked at, it's alongside your flexed walk stance type position, facing forward, your various holds. That will not work well for certain individuals. A really good illustration of that is people with dementia. If I stand in that classic, this place, someone with dementia is looking round at me like that, thinking, what are they doing back there? And they won't stand up for me, because you don't stand up forwards if you're looking backwards. That person would benefit from a very different approach. So I might actually be in front of them, gap filling, giving a lot of visual and tactile prompt to stand. But they must have the physical ability to get up. It's just the dementia is preventing them from standing. And someone at a training would look at me and say, oh, you're not allowed to stand there, front assisted stand. No, it isn't. Are the principles correct? Am I flexed? Am I stable? Am I facing forward? Do I achieve the outcome? Have I created any harm to the client? If I pull them up, then that's not right. A principle's been broken. So you may need to be able to use evidence to support what others would see as questionable, but I've got to be able to defend my position. So I would look at REBA, and I'll do a REBA on the practitioner and say, is there any postural information that tells me I can't do it that way? If there is, then I must think again. I'll look at Borg. What's the perceived exertion? Now, we use Borg a lot when we're looking at reducing double care packages down to single care packages, because what's imperative is that one carer isn't working twice as hard because I've taken someone away. They must be working no harder on their own than they were as a pair. And Borg will give me that. It'll give me a measurement to say, how hard were you working as two? And how hard are you working now on your own with this equipment? And interestingly, if you give people the right equipment, they're often working less hard on their own than they were previously as a double up. What they haven't sussed out yet, but will, is that if two people had the equipment I'd given the single person, they'd have been even better off. But equipment provision is what allows the exertion to be kept down when you've taken a person away. You've got Likert scales, you can use them for comfort activity. You've got Benner scale, skill level for carer, and there are other measurements for skill level. So I will be using those sorts of tools to evidence my variance in practice, plus my knowledge of the biomechanical principles that must be applied. Someone also asked earlier about how to influence change in a care setting that they've gone in as a trainer but don't actually have much influence over the other aspects, the ergonomic aspects of the management. And one thing, and I don't know if you've got this in your legislation, but it's been very useful to me in our manual handling regulations in the UK. In 2002, an amendment was added to our manual handling regulations, which said that in your risk assessment, you must take account of the physical suitability of the employee to carry out the operation, their knowledge and skills. And so when I'm trying to get slide sheets introduced, for example, and the management are saying, well, we've managed all right without them and we haven't any money, I'll just say, well, the law says we've got to do that. Because you've got carers who are working with musculoskeletal injuries. You can't get rid of your workforce who've got musculoskeletal injury. We have no one coming to work. So you've got to make suitable adjustment to their work. Slide sheets, or even better in some cases, in-bed sliding systems, so you haven't even got the bother of putting the sheet in and take it out again, in the right assessed circumstances, of course. They allow any person to move someone in bed, not just the physically able carers. And that means I'm complying with that legislation. I'm taking account of the physical suitability of all my employees to undertake the job. I could do it differently, of course. I could assess them and say, only you lot can do that job and only you lot can do that job. But as a manager, that's a very poor way of managing your workforce. It's much better to get your systems right so that anyone can do it. But the legislation can underpin my request for equipment or whatever. Looking at the ergonomic design of equipment, knowing your equipment sufficiently well that you know the pros and cons of it all. So if we look at those bits of equipment, and we know that assessment must take account of the security and stability of the individual we're moving, that top left-hand version of a standing turner depends on counterbalance technique. The carer has to stand holding on, counterbalancing as the individual pulls themselves up into stand. And the essence of counterbalance is having remotely equivalent weights on either side. Do we take account of that in our assessment? No, we just put in the piece of equipment, and every carer who goes to look after that person is expected to counterbalance it, whether you're 6 foot 16 stone, 5 foot 6 stone. And that can't make sense. So some people will be well able to do the job and others will be really struggling because we haven't taken account of their individual capability. It also means we can't do 2 tasks at once, that bit of equipment. I can't counterbalance and keep you secure on there and help you with clothing, adjust to sit down onto a commode. I can't do both jobs. Do I put in 2 carers to do the job? Do I choose particular staff to do the job? Or do I simplify the whole thing by putting in a different bit of equipment that eliminates those problems? And that's the essence of ergonomics, is eliminate the problems at source. So if that piece of equipment is causing me problems, and I'm not saying, we can't use them, we can, but it will bring with it certain issues. And if those issues are hard for you to manage, then change the equipment to a piece of equipment that designs out the problems you're having. And so we've got 2 different things there. We've got the Arjo Steady, which means that I can manoeuvre the person a bit when they're up. And one of the difficulties of standing turners is they're never in the right place for the leaving point and the destination point. You're too far away from one or other. So if you've got someone on wheels, that doesn't matter because I can adjust them towards or away from each destination. I could eliminate the difficulty of different body mass index ratio by using something like the solo turner, which self-counterbalances. So once the bar is out, a carer hasn't got to stand there anymore. They can let go, come round and deal with clothing or move the chair in behind them. And it's having sufficient knowledge of your equipment to know what does what well and what situations would benefit from that. I think I've said all that. If you're going to get people to buy equipment, you've got to be able to help them to see there isn't a financial drawback to it. Care shouldn't really be cost-driven, but inevitably it is. And we all have to be aware of costs and spiralling costs and manage things well. And what you've got to be able to do when you're asking for something to be put in place is to look at the cost-benefit analysis of it. And I was involved in a pilot project in 2009 with a social service in the southwest of England. And we were looking at the reduction of 2 carer packages. This is in community settings in people's own homes. Reducing 2 carer situations down to single carer managements. And trying to identify not only cost benefits, other benefits as well, but the drive was around a cost-benefit analysis. And if you look at the, my pointy thing. If you look at that line there, this is cost and this is time. If 2 carers go in to deliver a care support, the cost over time just goes up indefinitely. The cost just keeps growing. If you put in suitable equipment to meet the person's needs to be able to be managed with a single carer, although the initial cost is significantly greater, by putting 1 carer in, not 2, that's the line that you get over time. That is your break-even point of the cost of your equipment. From that point on, you are saving more and more and more and more money. Does that make sense to people? And that was the essence of convincing OTs who always say to me, oh, we can't put that in, it's too expensive. And I'll say, it's expensive, but it'll save you money in the long run. On the pilot project, this initial cost per case was about £750. Some people had a lot more, some people had a lot less, but the average cost was £750 per case. And the average break even for that £750 was 6 weeks. And even if I put in an all singing, all dancing £3,500 rotating bed that stands people up, so I've done that in one case, a plus size individual who was having 3 carers for every transfer in and out of bed. We put in this, it was at least 3,500, it may even be more, I can't remember exactly. But he managed with 1 carer. And even on that case, massive amount of money, plus other equipment we put in, although the break-even point was 15 months, on a 10-year care package, we're saving substantial amounts of money. So the cost benefit is huge over time. And we saved £20,000 a month on 30 care packages. And some councils have saved significantly more as they're looking into reducing care. So this is another illustration of where we've used costly care package. So we've put in a high-low profile bed, we've put in a Wendelet base layer, which is a slidey, semi-slidey surface to facilitate independent movement in bed. For a gentleman with Parkinson's disease who had difficulty getting in and out of bed, that's all he had a carer for. We put in the Theraposture leg lifter, which stabilises him. He's got a handle he can hold on, he's got the profile bed he can lean into, his bottom doesn't stick to the bed because he's on the Wendelet base layer. And this leg lifter puts your legs onto the bed, not just alongside the bed. And then it retracts. And so he is now independent getting into bed. He doesn't have a carer at all at night now. Now, the cost of that is hugely beneficial. Although that package was substantial, probably was about, I can't think, it was 15. It was about £2,500 to put that equipment in. But he now is independent. So that will recoup relatively quickly. Another common set of equipment we use are these in-bed systems. The two we commonly use, and there are plenty out there, but these are probably the lower level interventions, and that's your Romedic Wendy-Lett bed system and your Philislide Biotexus in-bed system. And they allow you to manoeuvre people within bed or have independent movement within bed without having to insert and remove slide sheets. Of course they're not suitable for everybody, nothing ever is. But they have helped us enormously in single carer managements. Just said all that. There are obvious benefits to the individual, and it's not just a cost-saving exercise. You improve dignity. If you can get people to mobilise for themselves or feel part of the mobilisation, it improves dignity. It's less stressful and invasive, both physically and socially. And it gives us a flexibility in care routine that we might not have before, and it's very empowering. But if we're going to put a change of intervention like that in place, we must support it with evidence. And we've talked about all of those things, using your biomechanical evidence, using tools to give us actual facts and data, looking at skill levels, competencies, etc. The framework for the single care intervention was to improve functional ability and confidence, to demonstrate that we were making balanced decisions. We had to keep a broad vision on what equipment was available to us, even relatively high cost equipment, and make a case for that, and involve anybody who was central to the situation. Obviously have to do a good activity analysis, undertake a task analysis, identify the current difficulties for that individual in achieving the task, and we set staged goals for them till we got the desired outcome. Recognising that a task analysis is your systematic analysis and recording of the human work activity. So you identify the risks, you look at usability and effectiveness, you look at what instructions and aids are needed, what the system of work is going to be, and how that's going to be maintained. And as someone said earlier, documentation is critical so that people have got the right information in the right place. So here's a situation that has got training implications, it's got practice implications. We're using single carer to move someone up the bed. And this is where you have to explore whether your training supports the practice that the carer is going back to or not. The essence of a slide up the bed, the principles, if you like, for the carer are that they are on a stable base, they're on a base that they can transfer their weight over so that they're not pulling with their arms, they are manoeuvring with weight transfer, that they've got their spine in line, they've got a good hold, all of these key principles which I'm sure you're very familiar with. If you teach that as a very forward technique, in other words, you're literally parallel to the bed to move the person, so I'm moving up the bed with them, that's a very standard core skill that many teach. However, it doesn't lend itself well to a two-handed method because you're too far away with your outer arm unless you've got equipment that brings your arm, it gives you a handle that's extendable. If you teach the going up the bed sideways, I'm not going to get into a debate on that because there are all sorts of evidences that demonstrate to us that is a musculoskeletally inefficient method. It will not work at all with a single carer. Nor, unfortunately, will the very straight down the bed method, because there's no tension across the bed. So you have to adapt your technique very slightly to teaching carers to use a tug-of-war position for sliding, which is walk stance, face forward, hands in front of you, and move by transferring your weight. Now, if you teach that, they can take that and translate it into any sliding situation they want. They can use that standing at the top, at the head of the bed, behind the head of the bed. They can use it as a two-person technique or a single person, but what they have to remember is, as a single carer, you have to stand at an oblique position. So I'm looking across the bed. It doesn't show terribly well, this probably shows better there. Can you see that I'm actually looking diagonally at the far bottom corner of the bed? But I will move backwards. I don't move up the bed, so I'll just come to this table and show you. I'm standing like that. What I mustn't do is go up. What I must do is bring the person to me. And carers find that a little hard at first because they want to move the person up the bed. They've got to stop thinking that. They've got to think, bring the person to me. Now what happens is the person moves up the bed, but across a bit. That's fine, just go around the other side and move them the other way. So the person actually zigzags up the bed if you're a single carer slide. And as a trainer, I'm always trying to find methods that will work for carers in every setting. I can teach them lots of different methods, but it's not helpful because they don't quite know what to use when. So I'd rather look for techniques that they can sort of use in as many settings as possible. And if I teach this diagonal approach, they can use it on their own, they can use it as a pair, because although you're both moving diagonally, if you look at physics, if you pull like that and like that, the person in the middle goes straight. So I can teach one technique that applies the principles but can be used in any sliding situation. Or I can choose to teach them a two-person technique, a technique from the top of the bed, a technique on your own. They've got to learn 3 things instead of 1. And to my mind as a trainer, it's easier to teach them one that does everything than 3 separate things. Equipment can eliminate. So one of the hardest jobs carers do is... am I running out of time, by the way? No one seems to be. One of the hardest jobs carers do is supporting people inside lying for personal care. And actually we can eliminate that static work, that static posture completely by putting in turn devices from hoists. So that A, you've eliminated static posture, static loading. It's much less traumatic for the patient because they're not being held in intimate places and they're not underneath someone's arm looking at the floor. They're in a position that they can actually talk. But it also means I might, in some situations, be able to release a carer so someone can do it on their own. So whether you're assessors or trainers or practitioners, it really doesn't matter. You've got to say to yourself, have I got the right knowledge, skill and experience to match what I'm doing? How do I develop my knowledge, skill, experience? Make sure that you're learning stuff that is valid. question people. So I like people on my courses to say, well, why are you doing that, Sheenagh? I do it differently. If I can't justify it and base it on evidence, then I shouldn't be saying it. And I must be open to differences in practice as differences, but know when to judge whether if it's different and wrong. Our training must reflect current practice, and what I haven't said enough probably is it must include problem solving. You can't just do core skill training and expect people to transfer that into the many, many different ways they've got to use it. You need to problem solve. You need to say, that's your basic sit to stand. Now let's look at how you get someone off a bed, off a sofa, off a loo, because although those are all sit to stand, if you don't problem solve around, well, the person's like this, where do I go, how do I hold them, they can't apply their knowledge to real workplace situations. We're trying as trainers to not just develop people who can copy rote what I do. I want to develop practitioners who can reflect on their own practice and make judgments. And do get familiar enough with the legislation that you can use it to help you get things done. That's really useful.